Welcome, welcome. We'll let everybody join in. We're so excited to have you here. We always like to do a quick reintroduction to our next Excellence Through Mentorship group and just highlight all of the different work that we've done thus far. We typically have seminars that dig deep. So in our first series, we talked about self-care, allyship, and innovation, and these are some of those speakers. Then we took a journey upon how do we inspire the next generation. We talked about leadership. We talked about pipeline building. We talked about teaching and how do we become the best writers. And we had these speakers. Then we took it to advocacy. And we talked about how do we do state advocacy, federal advocacy, how do we do advocacy where we're at, and how do we look at it in a global context? And now we're in our Room to Grow series, and I'm really excited to have you all here. Thus far, we've talked about climate change, neurodevelopmental disabilities, emerging topics such as AI, and now we are going to focus in on deaf mental health. So I invite you to Lost in Translation, Communication, Culture, and Care in Deaf Mental Health. We have our wonderful speakers, Dr. Adrian Allen, Dr. Safran, and Dr. Prevy. And with that, I will stop sharing and I'll let them introduce themselves and what brought them into this topic. So we'll start with Dr. Allen.
Hi, my name is Dr. Adrian Allen. I'm a child psychiatrist in Rochester, New York. Um, I'm currently in an academic medical center at the University of Rochester, in an outpatient child and adolescent clinic, where we have the all comers, but Rochester has the highest per capita of deaf, hard of hearing people in the United States. And so we do get some deaf, hard of hearing patients, as well as CODAs, which are children of deaf adults. We're not my clinic is not part of the Deaf Wellness Center at the University of Rochester, but we are, it is alongside of us. And part of my interest, growing up in the Rochester area, I was exposed to some deaf, hard of hearing people working at a summer camp, and then joined a deaf interest group in college. And 30 years later, I ended up marrying a deaf man. And so we sign at home, and I have a stepdaughter that's a CODA, and that's what's gotten me interested here. So I don't have very many deaf, hard of hearing patients or CODAs right now, but I do get them periodically. So.
Dr. Prevey.
Hello, my name is Danielle Prevy, and I'm using interpreters, obviously. I'm a deaf individual myself. I am a psychologist, and I work in the DMV area. I'm also working at the Gallaudet Institute. I did set up a clinic for the past 2 years, almost 3 years, for the community in the DC area, as well as all over America as well. So I am mostly doing some assessments for psychological assessments for deaf children. And most who are referred are autistic, not just a single disability. I do see a variety of deaf, hard of hearing children. Sometimes I will see some deaf adults as well. The reason why I'm interested in this is because it's my job. I'm a deaf person as well. I do know Brandon from my previous job. I guess that's why I'm here as well.
I'm Dr. Safran, Jeremy Safran. Oh, were you going to say something, Brandon? Just to tell me. Um, and I am a child and adolescent psychiatrist. I also am working with adults too. I grew up in the DC area, so I think at a very young age, I probably was familiar with Gallaudet as a space, which is where I'm at now. I was trying to think about when exactly I maybe started down the path that where I ended up back at or at Gallaudet. But I took maybe one ASL course in undergrad, and I also have very limited signing capabilities, even still, even though I've been at Gallaudet now for a few years. Um, but they're slowly growing, and there was some interest there. I did my residency at George Washington University, so again was in the DC community, and experienced working with some deaf and hard of hearing individuals and patients. There was one rotation at Gallaudet, so I heard of that, but I actually didn't do that rotation. And I remember wanting to, but I just got placed for a different site. Um, and then was at Children's National Hospital, so still in the DC area. And Dr. Newsom reminded me of, the individual patients that also kind of ignite a passion or kind of capture your attention and emotions. And we shared a deaf patient at Children's National on the inpatient unit, um, who had very limited language capabilities due to just limited access, and that was very meaningful. Then after residency, after fellowship, one of my co-residents who was at Gallaudet kind of put me in touch with the counseling and psychological services at Gallaudet, which is who had the GW trainees there, and they asked if I would want to supervise, but also see patients there, and so that's kind of how I got plugged back in, and I've really enjoyed my time there, and have felt that they've been very welcoming to me, and also it's been a really important part of my career thus far. So I'm there doing medication management, even though I do therapy in a separate outpatient practice. Every patient I see there has a therapist through the counseling and psychological services.
Perfect. Well, thank you all for your introductions. One quick reminder to everybody, since we're in the webinar format, feel free to put your questions in the chat. We'll try our best to, or in the Q&A, we'll try our best to get to them. If perhaps we aren't able to get to them, we plan on being able to answer them and send them out in an email. One thing I do have to give a plug for all of our folks who might be ACAP members, there is a committee for that, just for this. It's called the Deaf, Hard of Hearing, and Low Blind Committee. We'll post it in the chat. We're actually in the season for people to sign up. So if you haven't yet, do sign up for it in the portal. And with that, let's get to that first question. What are the typical mistakes made by hearing individuals in treating deaf populations? And maybe I'll lead that to Dr. Allen first.
Okay, one of the things that I see, an obvious one is when you're working with a deaf individual that is using an interpreter, is that providers will often make eye contact and talk with the interpreter rather than the deaf individual. I think the other thing that sometimes we see is just making some assumptions that deaf, hard of hearing people don't have the same abilities that everybody else do. So I think underestimating their capabilities and not knowing who they're really speaking to. That's probably the most obvious mistakes. I don't know, Dr. Safran and Dr. Prevy, if you want to add to that.
Yes. For me, I was actually talking with a colleague today. For deaf kids, a lot of times we rely on parents to report. Parents fill out the form, or the teacher is filling out the forms. And a lot of times the teacher or parents will over or underestimate the deaf child's ability. So that's where I think a lot of times I see, in the professional setting, they just go with it instead of really reviewing each question and be of that deaf impact, thinking how that is for the diagnosis. That's a common one that I do see.
Um, the I think probably the biggest one that I have noticed, um, and I think also, I remember when I was first starting out at Gallaudet, one of my colleagues, I think, really set me up to not have this problem because they kind of gave me this advice heading into it. But if you haven't had a lot of experience interacting with a deaf person or experiencing that difficulty in communicating, to just say, oh, I'm going to avoid this altogether and I'm not even going to try to communicate. Or um, there can be sort of like in ignoring that individual who's there, which maybe is also present, like Dr. Allen was saying, of looking at the interpreter versus looking at the person who is signing, or the patient that's in front of you. Um, and maybe also tied to that, I think this is something that, like a skill almost, that I feel like I've developed over time, is picking up on when miscommunication happens, like when there's a communication breakdown, which can sometimes be subtle. It can happen, I feel like, with the best of interpreters, and it can happen with any patient too. Um, but that's something that I feel like has been really important. And then um, just another piece that I would add is just the cultural awareness that I think is vital with any patient that you're treating, but particularly stands out, I think, working with this community, and recognizing what kinds of implicit biases there may be present, or um, how also it impacts your interactions and the way that you're providing care too.
Perfect. I mean, you actually led to my next question. What are some aspects of deaf culture, and what can we do to help when there are these intersections between the cultures? And maybe we'll give that to Dr. Previ.
Okay. So in the chat, I had mentioned a word about big D deaf and little D deaf, what the differences are there. So I would like to explain each of the how the deaf community responds to that, because more and more people, deaf people, have cochlear implants, are using cochlear implants, and are using many, many different ways of communicating. They still feel like they are part of the deaf community as well. So basically, a big D deaf means a person is not focusing on their hearing status or medical perspective, medical view. They are part of the deaf community and using sign. So that means hard of hearing or cochlear implant users could or even consider themselves culturally deaf, but some prefer not to identify as big D deaf. So that's where the small D deaf comes in. They have more of the medical view, medical perspective. That's where that separation comes into play. And let me actually go back to the actual question. It was in regards to cultures, correct? Like deaf and other cultures. Is that what you are meaning?
Yeah, when they intersect.
Okay. Yeah. I think the big one that comes up most recently was for the term deaf blind. I have noticed that deaf adults who start to pick up that word are using that term, but with deaf children, they're educationally taught hearing impaired and visually impaired. So when you think about an IEP, they don't use the word deaf blind. So we have to go back and forth and really convince them to use the word deaf blind. And I think the deaf blind community itself now is screaming to become more recognized because of that term still not being, I don't want to say accepted per se, but recognized. So that's why I am trying to do my part by bringing up the IEP, bringing this up to the IEP team of that deaf blind terminology. deaf and visually impaired really doesn't apply because there is a high percentage of individuals who are deaf themselves who have visual issues as well.
Thank you. Actually, when we talk about this, what would be the gold standard for communicating with deaf populations? Are there layers to that? What happens when, it's not necessarily you can't immediately get the interpreter? How do we best handle that? And maybe let's start with Dr. Saffron.
Yeah, I think almost as just one of the initial questions that I'll ask is just what a communication preference is for that patient. So not making an assumption and asking that question, I think because I'm, within a clinic at a school that is centered around deafness, there is I don't know. I automatically it's a part of that practice, but maybe if I was in a different setting, that might not be a part of my initial questions that I ask for every single patient that I see. But I think if it feels like it could be at all relevant, it can't hurt to ask that question. Um, and it's not then making an assumption, or I think which could go both ways of making an assumption that somebody doesn't need an interpreter or making an assumption that somebody does when they felt that they didn't. But asking what is their communication preference. And I'll also include that I know we think a lot as psychiatrists, sort of even, where people are sitting and placed around the room. But that is also another maybe just conversation that I start with patients and the interpreter of, how would we all like to have this room set up? And just being intentional about that. And I also, this might be obvious, but, sometimes with urgency or in emergency situations, you aren't able to meet that, gold standard or what you really would like to be doing. Um, and again, I mean, I think like I was saying for the first question that you asked, um, if something isn't quite at the level that you feel would be the best form of communication, that maybe doesn't necessarily mean that communication needs to be shut down altogether. Um, I'm thinking of one particular interaction I had, which I probably could say, went well and didn't go well in certain ways, but it was a deaf-blind patient that I was working with, and they, we had our CDI, which is a certified deaf interpreter, which I can explain what that is as well, but it is the interpreter themselves is deaf and is interpreting the sign language from the patient to then sign to the speaking interpreter who then would use spoken language for me because I don't sign, or I'm not able to sign well enough. And so the speaking interpreter, though, just I guess had missed the appointment. Something had gotten miscommunicated, and so it was just me, the CDI, and the patient. And I could have said, "Hey, this isn't going to work. We're not going to be able to see each other." And part of me maybe feels like that might have been the right decision at the time, but also I ended up, using what limited communication we had to ask the patient what would they like to do and asking the interpreter what they felt comfortable with. And we ended up having, luckily we had an hour scheduled appointment, but I feel between, the patient signing, the interpreter then typing out what they signed to me, and then me typing out to the interpreter who would then sign back to the patient, I quickly realized that I maybe had like 6 questions. And we were starting late because we were waiting for the interpreter for a period of time too. And so I knew I had 6 important questions that I could ask. And I ended up still, okay, let me go through the really vital questions that I need to ask this person. And I really felt, shucks, that was a terrible interview in my head. I'm thinking of I did not get to ask nearly as many. Like I maybe got to ask 5% of the questions I might usually ask somebody. And at the end, though, of the appointment, this really stuck with me. The patient said to me, I really appreciate how much time you spent with me and that you were actually asking me questions and listening to my answers as if he had never had that experience before, when in my mind I'm thinking that was so not up to the standards of what we would all like to be providing of care, that it still really was significant and meant a lot to him. Um, and yeah, that moment just really stuck with me of just not saying, hey, if things aren't exactly the way that they should go, it doesn't necessarily mean you can't, recognize that and say, hey, we got to do better next time, but also making sure you're trying.
Perfect. Thank you. I have another question. Speaking as you think about the mentioned the psychiatric interview, how do you adapt that when there might be more serious mental illnesses, such as things like psychosis or other things? And I'll direct that to Dr. Prevy.
I personally don't work a lot with severe mental illness. So maybe the other two would be better to respond to that question.
Absolutely, Dr. Allen or Dr. Saffron.
I can also say that I don't see very many severely mentally ill children or adolescents. I did have several years ago a young girl who talked about the party in her head, that there was just so much going on in her head at one time, and we weren't sure whether that represented any kind of hallucinations. Um, After a little while, and I did not have a CDI in that I was working at a state hospital in a different part of New York. So we didn't have a certified deaf interpreter available, but I had a wonderful interpreter that was consistent. So we did our best to have the same interpreter every time. So as I got to know this girl and her family, it was more and more apparent that she had some real language deprivation. Her family was hearing, they did not sign. There was some instability in the family. They depended on her doing a lot of speech reading or lip reading, which is not very reliable at all. So it wasn't until she actually started attending the school for the deaf that was closest to her community. And that was when her language really started to emerge. Once she really got access to language through ASL. She had a cochlear implant, but wasn't able, and I think somebody has a question in the chat or something. She has a cochlear implant that wasn't allowing her to experience language in the way that hearing people experience language. And I don't think she had adequate speech therapy at the time. And so her language was just so poor that we were almost concerned that there might have been some psychosis, but it turned out that she was a young girl with poor language skills and ADHD. And once we got that figured out, she blossomed and was really good. And so backing up to one of the previous questions about the gold standard, as well as mistakes that hearing people make, is assuming that deaf, hard of hearing individuals can speech read. Um, um, and also assuming that deaf, hard of hearing people will make things easy for us. And that's not how it works. So when language breaks down, going to writing, texting, we do whatever we need to do until an interpreter arrives. And we follow the lead of the patient, the client, if they want an interpreter or not.
Thank you. And I know a question was posed in the chat. How do you determine when miscommunication has occurred outside of body language, which may or may not be an assumption? Feel free for anybody to take that.
I mean, I think that's always a difficult thing, right? Because kind of by definition, if it's a miscommunication, it was kind of outside of somebody's awareness, or some aspect of it, right? But I do think what that the person who asked the question highlighted of body language sometimes being an important piece, and it can um, there may be subtleties of, I don't know, some things maybe jump out to me of um, it could be a little bit of a gut feeling, but I think that there is some kind of a mismatch happening. I don't know if that's exactly the right word to use, but I'm imagining, if maybe there may be some obvious ways in which the conversation is starting to go in a direction that you didn't intend for it to, of wait, okay, wait, where was the miscommunication? Because that wasn't exactly the question I was asking. It may be a more extended back and forth between the interpreter and the patient kind of cues me into, okay, wait, did I ask that question in a really clear way? Um, it could be, again, just reading some other cues, if it's nonverbal facial expressions or there's a I think that there, even being somebody who does not sign fluently, you can interpret a degree of almost tone or prosody based on sort of the rhythm that somebody might be signing, or um, maybe some emotion present, again through nonverbal, but also through the signs themselves, that could kind of just cue you into, okay, wait, something is feeling a disconnect. Let's slow it down or take it back a little bit, or clarify, or not clarify, repeat, to make sure that you were clear or understood.
Thank you. Actually, shifting a little bit, how do we support hearing parents take care of deaf children? And maybe let's start with Dr. Allen.
I think if we can get to hearing parents really early and let them know that ASL gives their children the best introduction to language, the best access early on, and that going 100% oral is really limiting for deaf, hard of hearing kids. I think Dr. Prevey can probably add the most, but I think language access is so important. And we know that in our kids on the autism spectrum, that the earlier they have useful language, the better that they end up doing. But I think hearing parents are often fearful of, oh my gosh, my child is deaf. How am I going to connect with them? So they want to do the oral method and just only speak to their children, but that gives them much more of a language delay in the long run. The other thing is really encouraging our hearing parents to learn to sign themselves, to really put forth some effort to improve that relationship starting from when they're very young. It's quite it can be quite devastating to see kind of what happens in families, including my own husband's experience doesn't have a relationship, doesn't have the same kind of relationship with his parents and siblings that I have with my parents and siblings as a hearing person. And so there's something when we think culturally, there's the dinner table syndrome, so that when a deaf child and their siblings and parents are all hearing, they're sitting at the dinner table, everybody's having a conversation, but there's often a tendency to, oh, you missed it, you wouldn't get it. Oh, never mind. Oh, I'll tell you later. And that person is often left out and very isolated. And so it really makes you be the minority in your own family. And so telling hearing parents ahead of time, well, not ahead of time, but once they get that diagnosis for their child, these are the things that we need to do to keep you all connected and to have you relate with your children the best.
Yeah. So I want to, um, okay, we'll switch interpreters.
So as far as early intervention work, so I really encourage all of my providers to really fully understand that early intervention work. So they are able to understand how language deprivation happens. I work with a cochlear implant team at two different hospitals. I truly believe that all cochlear implants teams in the country should have a psychologist on their team in order to make sure that we are preventing any misunderstandings, preventing language deprivation. Oftentimes, I'll see parents will, they don't see the world. It's always going to be hearing. The world will not stop talking. So if a cochlear implant isn't working, specifically, or if a kid's in progress with speech therapy, using sign to communicate is necessary. Maybe later on they will pick it up. Maybe they'll pick that language on later on. And I can say that, globally, it's not, no one is going to stop talking. Your parents need to respond better to that.
So,
Can I add just a quick thing to what something Dr. Allen said too, of that sort of image at the dinner table and one parent saying, "Hey, we'll tell you later," or I just feel like that has been a very painful image that I've just heard over and over and over again working in the deaf community, some variation of that. Um, and like we were talking about, or Dr. Brevi was talking about with, language deprivation, then also potentially leading to social deprivation. And in the dinner table example too, of there can be like emotional deprivation too, or that pretty, I don't know, constant and early emotional injury that I feel like isn't uh every not every patient that I see, but it is, I mean, probably some variation of that to a degree at some point in their life. There has been a moment like that, and it is just extremely common too. And so that has been, I think, maybe that emphasis of, learning to sign to be able to communicate with your with that family member, and also, um, I know there's probably a lot of barriers too for families to be able to learn to sign. Um, but I think being able to communicate it, empathize, and support parents feels crucial to that.
And I think it also goes the direction when the parents are deaf and the children are hearing. Um, there are equal communication problems then, and sometimes in I don't know how you call what you would call it, a deaf hearing couple. So if the deaf hearing couple has a hearing child, very often again the language is English and spoken, and there's that separation between the deaf parent and the hearing child. And I've also had families where if the parents are both deaf and the children are hearing, the oldest child often has the best ASL. And then one of my families, it ended up that the parents depended on the older child to speak to the younger child to communicate. And so the younger child's signing was incredibly poor. It was amazing to me that this child, his skills were really poor. And then my own stepdaughter, for a long time, her skills she just got really lazy. And her mom is hard of hearing and her mom used her voice, but her father doesn't use his voice. And so that communication gap really widened. And so it's important, both directions for making sure that the communication, and this really reduces the behavioral issues that'll happen in the family if when you focus on um, improving communication.
speaking of improving communication, one question is, are there any media representations of deaf and hard of hearing populations, or influencers or movies for people to learn more. And maybe I'll start with Dr. Preevy.
I think Instagram has a lot of parents of deaf children and a good variety as well. We're having parents of successful CI users. We're having parents of, who may be using ASL even more. So I think that that type of variety is very well represented through parents who, you know, have some variety in what it means to be deaf. Um, like The Bachelorette, there was one woman who was using a cochlear implant herself. She only spoke. They have movie stars who are signing only. So honestly, I feel like at this time, it's a really good time to be deaf because there are so many things out there, in regards to social media and movies themselves.
Absolutely, and I saw a couple, Sound and the Fury 2000, The Silent Child, Switched at Birth. Dr. Allen, Dr. Saffron, anything else y'all want to add to everybody's collection to view?
I remember.
Coda was the most recent one.
Yeah, I was gonna say Coda as well. Which feels a little bit like a cliche answer, but also that may be why it should be said too. Um, it was a good film and I think captured some important stuff. And then I remember watching a PBS video, or maybe it was a little bit longer, but called Through Deaf Eyes, which I'm sure is searchable, but that talked about um, deaf culture and had like quite a variety of firsthand experiences too that I thought was pretty helpful in just learning.
Perfect. All right, I'm looking at some questions from the chat. I see one that's asking about any current tech initiatives seeking pediatric psychiatric expertise and where people can go to learn for that integration between tech and deaf populations. And if we can't answer it here, we will get that answer to you and send it in an email. But any of our panelists want to take that?
I don't know of any, but I just feel, I mean, at least nothing's coming to my mind right now, but just with how much is being done in the tech space around language right now and learning models, I've got to think it's got to be a pretty booming piece. I know there are some very effective voice to text apps, for instant voice to text. Um, but that's what's coming to my mind at least.
I do know that more apps are speech to text apps. They now have the ability to detect what we call deaf accents because there are some deaf people who prefer to use spoken English, and they don't want to use sign. They don't know sign. So there are more apps that are picking up that concept even more, picking up deaf accents and being used. More AI companies are producing signs material, I should say. And there are some, I don't know the name of them, but I know that there are some apps. They are developing technology of hearing people speaking, and then it will produce a signed video. So it is a growing area right now, definitely.
Perfect. Thank you. Dr. Saffron, I had a question for you. What are especially for your population, what are some sports we should be advocating for in emerging young adults?
Yeah, I think the things that stand out the most to me are, well, obviously, depending on where you are nationally, access to care can just be a problem by itself, no matter who you are, and mental health care, but particularly for deaf patients. And so there's a fair amount of online telehealth, especially for therapeutic services, of finding a deaf therapist. And I'm sure we can share a list of those that are valuable, but um, or that could be helpful. Um, I think just even locally, so in the DC area, there's such a breadth of mental health resources, but still, I think it can be a challenge in finding some higher level of care that feels that it is equitable for, and this is not meant to be bashing anything, but equitable for deaf patients in terms of like inpatient experiences. I've just very commonly heard of having really unpleasant inpatient experiences from patients, and I guess that applies nationally because I see patients who are coming to DC from um, all over the US. So it's not specific to just DC or also specific to areas that don't have access to mental health care. But really, like interpreting services just feels so essential because ideally there would be a deaf psychiatrist or therapist who would be working with a deaf patient. Um, if that, to be able to work with somebody who communicates um, in the same way, understands your community, and you can connect with, at least for that to be available, right? But at the very least, it feels like an absolute essential that's not always there of having adequate interpreting services. And so, really advocating for that. Um, and like, I have called emergency rooms for patients that, if I'm thinking of an instance of, in FD12, which is the assessment for an involuntary emergency room and then potentially involuntary admission to a inpatient unit, and knowing ahead of time how packed an emergency room is, how busy it can be, and how likely miscommunication and how quick communication happens there. You can kind of imagine what it would be like for a deaf patient in an emergency room, that has possibly like an iPad, and that's how they're communicating, and they have to plug it in, and um, you have a poor Wi-Fi connection that you're trying to communicate something through. But I really think going out of your way to speak to the provider yourself feels that's there's a particular instance in my mind that stands out of talking with them through about what is going to be the best next steps for this patient, and finding intensive outpatient care, inpatient care that is just even good enough, I think, is at least a first step.
Thank you so much. A couple of questions that got asked in the chat. What resources are there available for people whose first language might not be English, especially in learning ASL or any other sign language? And maybe we'll get it to Dr. Prevey.
Not a lot, not a lot, but I do know Spanish-speaking families, there are a lot more resources for them. I have worked with a lot of Middle Eastern families or Indian families or Pakistani families. That their spoken language, there are interpreters that did not understand what deafness was or cochlear implants. And so there was a huge barrier there, and it was really hard to try to explain the concept of signed language. And so it just required a lot of pictures, a lot of time with the spoken language interpreter. Um, and in the deaf school that's close to me, really helped out a lot because they spent a lot of time with the families as well, providing education and on what deafness is or cochlear implants or things like that. So, in general, the resources are not easy to find. You have to be really creative.
Perfect.
Just
Thank you.
two
Go
things
ahead.
just really quick that came to my mind. So I think ideally just trying something to see if it would be a good fit. So if there's, on like something that would be relatively free and low risk for someone to try out. Um, I think that there are free course. I know that you can do some paid courses, but that's an investment in learning ASL. But there are also some free online courses. I think the Oklahoma School for the Deaf maybe still offers them, but I remember seeing that at one point. And in terms of like those maybe I don't niche doesn't feel like the right word, but um maybe specific and um the specific needs. I would imagine like just in learning any language, although Dr. Allen, you'd probably be the person to really answer this question in learning ASL, but like one-to-one tutoring feels like that could be a really good opportunity in that situation because you could have a really matched experience and also somebody that you could kind of work with over time too.
It really depends on the resources of that a family has. My own personal experience, once I met my husband was and learning that he was not going to use his voice, and that he was only going to sign. I worked with a deaf tutor one-on-one for several sessions. In the Syracuse, New York area, they had a deaf uh, coffee social, if you will. So every Friday night, members of the deaf community, as well as a bunch of ASL students, would gather at different Panera Bread restaurants, and it was a no voice zone. And so it was only signing. And so sort of immersion starts off pretty overwhelming, and then you get a little bit better. And then I took some formal classes myself at a community college. Um, the um, but there are certainly, lots of the apps out there right now. I saw somebody put in either the chat or something about whether or not we can do some ASL at classes at the ACAP annual meeting. It's an intriguing idea. I don't know what would be who would give us the time and space to do some basics. But in my experience, making the effort to communicate with deaf and hard of hearing in their preferred language is goes a long way. Um,
This might be a digression, but that just had a thought pop into my head too of as I have been very slowly picking up some ASL, but even imagining, if I had as much opportunity to pick up the language as possible, um, that it still, would I feel comfortable using I still the value of an interpreter is maybe just what I wanted to emphasize and the necessity of it because it's one thing to be able to sign for um, small talk or conversationally, but then to transition your clinical, expertise also into that language, I feel like is quite a step, which I can't imagine. I feel like that could be decades of, learning a language to really feel comfortable that you're providing the level of care that that patient deserves. But what Dr. Allen was saying of like the amount of rapport that even just being able to fingerspell can build for patients can be pretty huge.
Thank you so much. And I know Quentin just put it in the chat again. Like if you want to join if you're a ACAP member, you want to join the Deaf, Hard of Hearing, Blind, Low Vision Committee, please add yourself to the portal. We would love to have you. I then had another question. How do we find therapists who are competent in taking care of deaf populations? And I will leave that open to everybody, but actually I'll direct it to you, Dr. Prevey, first.
How do we find therapists? So really, there's a lot of it's a word of mouth. Um, because I know that we have a website site called Psychology Today, and sometimes they'll put if I put an ASL filter in there, there's a lot of therapists that will show up that say that they're fluent in ASL, but they're not. So I think sometimes when you're looking at where they got their training, sometimes that would give us a sense of um, do you have a good understanding of deaf culture or not? Do you have a good understanding of cochlear implants? Because a lot of times the therapist can sign, but maybe they don't have the best understanding of what it means to be deaf. So, cochlear implant use, language deprivation, and that type of thing. So sometimes it can be a real challenge. When I recommend a therapist to a family, I try to be very clear that maybe I don't know this therapist well, just in case, turns out badly. So,
Thank you so much. And then I saw anonymous question. How do we, language changes and, ASL and the other sign languages are a language. How do you track language idioms other than just asking patients themselves? Is there like a social media platform to keep up on the trends? How do you keep up to date?
I mean, there can be
yeah,
such
I
a
think
oh,
social media,
no, no,
really
no.
helps a lot because I'm still young. I'm still a millennial. So there's some Gen Z who their signs, I'm like, I don't know what that means. And so sometimes I would just ask them directly. Or social media does help a lot. But I will often see in other situations where the hearing provider um, there's an ASL interpreter, and the ASL interpreter will just kind of skip over that idiom and not really capture the humor of it or the joke or so I think it does impact that rapport and the diagnostic process.
Dr. Saffron?
Oh, I was just thinking there can be such a wide breadth of variations to language, or if you just think of it like with accents, right? There also is a variety of accents within signing too, but um, even if you don't know every accent and in recognizing it, that doesn't mean that you can't also know the concept of an accent and that there could be some challenges for the interpreter or again, like just moments of miscommunication or how it might impact the patient, um, in terms of, one individual may like shift their accent depending on who they're talking to, and that can have, an impact for just, I guess, all of us, in using language. Um, but just knowing the concept of it without necessarily having to know all of the facts, I feel like can be really valuable.
I did want to get maybe one more question in and then we'll get ready to close. Um, I guess there's a question, if a child presents behavior that's regulated other than considering language deprivation, what are other aspects that you're considering when thinking about the deaf community and thinking about vulnerability to trauma or anything such as that? Dr. Previ, you want to take that preview?
Yeah. So if a child has experienced language deprivation, there is a high chance for behaviors um, behavior disorders that can also lead to trauma. Maybe they're not able to communicate that they've been hurt. Um, and this is really interesting because I'm working with a deaf boy who now is 15, and I started working with him when he was 7. And I did an assessment in the beginning and then an assessment again, and we couldn't find a therapist. And so then at the age of 15, after he was able to regulate his behavior with medication and therapy and all of that, he developed better language. He started to disclose some of the trauma that he had experienced. And so, and once his sign vocabulary had improved, and so the behavioral kind of communication. So often when we're screening for possible trauma, I'm always thinking about how maybe medication can be helpful or sometimes harmful in some ways if they're not on the right medication. Because I'm thinking about maybe bipolar disorder or DMDD. And sometimes I feel like for those diagnoses, they overlap with trauma sometimes and try to figure out the baseline of the child's behavior to keep them safe and to give them the skills that they're able to report if they've been harmed or not.
Perfect. Thank you so much. And I think that, in the interest of time, because we're going to end at the top of the hour, um, any last thoughts or last comments? And we'll go in the order, Dr. Allen, Dr. Safran, and then Dr. Prevey. But I just want to, again, just remind all our ACAP members, if you're interested in learning more or doing more with the deaf, hard of hearing, or the low blind population, please, please, please sign up in the portal. If you have questions on how to sign up in the portal, please reach out to us. We will help you, and we'll get that done. So with that, we'll start in that order. Thank you.
Okay, last thoughts. It is that's kind of a broad a broad thing. I think reaching out to members of the Deaf Hard of Hearing Committee or other colleagues, now that you know a couple of us now, to get some additional questions answered, if that would be helpful before just jumping in blindly, if you will. I think that would be doing your best to learn a little bit about deaf culture, learning a little bit more about working with interpreters most effectively, and um, educating yourselves about the importance of early communication and language access, and making sure that parents know all of the options, and aren't just stuck with one medicalized view of um, how to support their deaf or hard of hearing child.
Thank you, Dr. Safran.
Um, yeah, I feel it'll be hard for me to exactly summarize all my thoughts, but maybe just to add on to one of the earlier questions around deaf culture, just being somebody who very much um, knew about it and was around deaf culture, but now have kind of been um, a part of it uh, for a period of time and really felt appreciated and accepted and maybe gotten to experience it. The word that comes to my mind is just there's a lot of pride and just pride in the community and the language itself and that maybe resilience that it takes also in living in a hearing world and being able to still communicate and connect with other human beings. Um, there was one presenter, I'm going to forget his name right now, but I remember watching, it was a Grand Rounds equivalent at Gallaudet on, it was an Austrian psychiatrist who came who worked with a lot of ID patients in Austria who were deaf or deaf-blind, and he gave, I think, almost half of the presentation without any actual language, like just in drawing pictures, gesturing, facial expressions, and he was able to communicate a story to us. And so just that there is so many different types of opportunities to connect with other people, that as I was saying before, just really trying and coming at it with kindness and good intention um, can be so valuable to a group of people that can be very vulnerable, but also are extremely strong.
Thank you. Now bring us home, Dr. Prevey.
Okay. I feel like when you're working with the deaf and hard of hearing population, learning to sign is important, yes. And I strongly encourage you to really study deaf people, the history behind deafness, and because, for example, deaf kids from the 90s to today, there's like it's like apples and oranges. And so the deaf community is constantly evolving, and there's so many variables with deaf and hard of hearing people. So I encourage you to really study about deaf history, really understand deaf culture and the meaning behind that, and that some people who aren't in the deaf culture, what that means. More importantly, than learning sign language. Sign language is always beneficial to fully understand what it means to be deaf, regardless of the communication preferences. And so that's what I feel like is most important.
All right. Well, thank you on behalf of everybody to our wonderful panelists. Hoping to give more stuff like this. And thank you, everybody. And we're going to close now.